My name is Gibore. I'm the General Secretary, Kenya Union of Clinical Officer. I come from Kenya. I have come here to attend the GACOPA meeting conference, which is bringing together the clinical officers and the physician assistant and other equivalent from the globe. I need to talk about the clinical officers in Kenya, about more specifically the training. The training for clinical officer was started in 1928, and it has been growing gradually because by that time we were only doing certificate. It went to diploma, that's in 1960, around 69. Then it graduated to now we have degree in clinical officers and also postgraduate. We now have around 5 postgraduate for the degree, and also we have 15 that is post diploma, which are different specialties that we train people in Kenya. They include ophthalmology, anesthesia, orthopedics, pediatrics, among others. And the profession has a very rich history because of what it is contribution to the health sector in Kenya. I want to say that we have been existing without any provision of the law, more specifically an act of parliament until 1988 when it was first established under the push of the association, then the Kenya Clinical Officers Association. Then under that, the act established now a regulatory body in the name of the Kenya Clinical Officers Council, which now regulate all the activity, the training for clinical officer. It also licenses them and actually always also in charge of all the training for the clinical officer. I have said that I'm the General Secretary for the union. It was registered in 2017. It's actually the youngest body for the clinical officer, but for the 2 years we have done tremendously good job, and our achievement is actually outside there to be seen. It includes of our advocacy to increase the number of clinical officers for the purpose of service delivery, and also to improve the training for the clinical officer. We have also advocated for improvement of payment, that's the remuneration for the clinical officer, so that they can look professional. This motivates these officers to do good work wherever they are, and in Kenya we are now in leading. We have actually also participated in the legislation process where we influence the policy for the health so that we can also benefit, because as much as we are service provider, we are also we also uses those services. The other thing I need to mention about our focus currently as the union, we have developed what we call strategic plan for the union, and our focus is actually to ensure that the clinical officers can continue to grow. We came to realize that we are called paramedics. Paramedics, to our understanding and in a legal understanding, is to mean that we are not professional. But the work we do is not in tandem with this thing called paramedics. So we are also, as a union, strategically position ourselves. We have engaged the WHO so that we can also will be able to explain ourselves to move from the bracket of the paramedics. In our country, we have the WHO representative by the name of Dr. Rodi, connected us to ILO, which is entitled globally to reclassify all the professional. So we have been engaging them. In the country currently, we have a go-ahead to be called professional. So when I insist about this, is about the importance of being called professional, because there is power by being called professional rather than paramedics. Because if you compare with the paralegal and the paramedic, then for us we are certified and we are able to do professional work. One thing I need to add about this is now to or rather to bring together all the clinical officers, the physician assistant, the medical officer assistant, to come in together and identify at least a common name. And that is now what we call the common nomenclature for all this body, so that globally we have one name that can be recognized and be associated with us once we move from the paramedics, and we can now be put at the professional, because we need the number. and the number can only add up if we bring all this country together. So that one is now gaining momentum through the AIPI and also now GACOPA, which is bringing the African, the Asian, the American, and every country. We will continue to do this because for us as a country, I think that one is clear, and the other countries are now realizing. We are focused to ensure that, because the union is to unite, we have to unite all this country that are training clinical officers, and also we ensure that we are focusing to streamline the curriculum and the training for all these workers, so that even if there is labor transfer or rather importation and exportation of the labor, it should be able to be accepted. The other thing we are focused is also to ensure that we push for the clinical officers, and it is equivalent to be allowed to participate in the worldwide activities on health, so that we are not forgotten, because worldwide the medical officers and the nurses are widely known. So the clinical officer had been left out, and the physician assistant similarly left out. So this is something that we want to bury, and our advocacy is not limited there, to ensure that also we are strategizing and sensitizing our member on universal health coverage. And that one in our country, we are the first people to produce what we call position paper, which we presented to the ministry on what is the role of a clinical officer. Like in Kenya, how do we help the government to achieve the universal health coverage? The government has actually received this very well. It has actually now provided for the government to employ, like this year they are focused to employ around 800 clinical officers to add to the number that we have. And this one will streamline also the service delivery from the lower level facilities to the high level. In Kenya, clinical office exists in all levels, from the level 1 to level 6, which is a referral facility. Now, when you streamline, you also streamline the referral system, which is a big issue in our country, more specifically Kenya, where people wake up and you just go to the referral facility when it's just a headache or rather something that will have been attended at level 1. And this issue of referral is also a big issue because, one, there are people in our country which are very poor. Once referred to seek services in a certain facility, which is several kilometers away, miles away from where you stay, this patient, if can't be able to travel, then they go back in their own cocoon and they go to die with this same problem. I want to say is as I myself, as the General Secretary, with all our leadership, starting from the union, association, and the council, we have formed what we call the top leadership, to streamline all the activities of the clinical officer, to ensure that we are in the decision-making table, so that we can actually sway the decision towards what we feel that is supposed to support the clinical officers and the patient that we serve. So by doing so, we have actually worked with the ministry very well, and we have engaged, like now we have a number of meetings that we have been engaging, so that we can contribute our rich knowledge on what the health should look like. And we have said that our advocacy is not limited there. We have to continue intensifying, and we will go outside our boundaries to bring all the clinical officers together. For new clinical officers, or rather new countries that are coming up with the program for clinical officers, this is my advice. First, that the clinical officers must define themselves. We should not let anyone to define us, because once they define you, they actually belittle you. They put you where you cannot move. For instance, I need to give a good example. When someone calls you an officer and the other one is called an assistant, then that's to mean you are an assistant to that person. So do not use the names that belittle you. Use the names that have power to demonstrate what you do. The other thing is that we must build ourselves. There's no one who will build us. Once you mute, then people think that you are comfortable, or either you don't know what you're doing. We must also come up with a good voice and with clear data to demonstrate that indeed what we want, this is what we want. And the other thing is that we must be able to change our attitude. First, from the services we offer to the patient, so that the patient are the first primary thing that we need to focus on. Focus on the patient, and then focus to ensure that you are not allowing yourself to be called names that does not augur well with you. And the other thing I need to say is that you have also people to benchmark. There are countries that are doing excellently on these matters of training of clinical officer and even advocacy. So please benchmark by participating in regulation making, policy making, and ensuring that your voice is heard. Do not mute yourself.